everyone. Welcome back to another episode of the Diabuddy Dialogue, a podcast brought to you by the Diabetes Hope Foundation's EDI Committee. I'm Afreen, and I'm joined by my co-host Rav today.
Hey everyone! In today's episode, we're diving into what diabetes care looks like from the other side of the table, through the lens of a diabetes nurse educator.
That's right. From helping people interpret their CGM data to supporting them through burnout, nurse educators play a crucial role in diabetes care. But the hows, whats, and whys of the work often go unseen.
So today we're bringing that behind the lens perspective to light. We'll be talking about what goes through a provider's mind during a short visit, how they build trust with patients, and what changes they wish they could see in the healthcare system.
And we are so thrilled to welcome our guest for this podcast, Rachna Gill, who is a passionate diabetes nurse educator who's been working in the field since 2010. She is a health nerd who loves exploring new ways to support wellness through movement, nutrition, and even mindset. Outside of her work, she enjoys spending time with loved ones, working out, and even creating content for her Instagram page where she shares healthy, kid-friendly meals complete with carb counting for kids living with or without diabetes. And it's called What's for Lunch, Ma?
And before we begin, we just want to remind our listeners that this podcast is for informational and educational purposes only. It's not a substitute for professional medical advice, your diagnosis, or treatment. Always consult your healthcare provider for personalized medical guidance. Now, to start us off, Rachna, can you tell us about your journey into nursing and what led you to specialize in diabetes education?
So I got into nursing because I was always fascinated about the human body. I always like to know why things happen and things like that. So like you've mentioned, I've been working in diabetes for about 15 years. And there's two reasons I got into diabetes. One, every time I had to take care of somebody that was on insulin, it really freaked me out. I got really, really anxious. Just insulin honestly did scare me because I didn't want to overdose, underdose, and because it's units, not mils, it was kind of, scary. So instead of avoiding it, I was like, you know what, let me learn about this a little bit more. At the same time, I was having a lot of low blood sugar, so I was dealing with a lot of stuff with my own health. And that's what led me to go into diabetes. And it really clicked both, I think, personally for me and also professionally. So that's how it started.
Awesome. Yeah, it's nice to kind of see that passion lead into a project and for it to kind of 15 years later, you're still here. That's as someone living with type 1, that's super awesome to hear. Now, what does a typical week for you look like as a diabetes nurse educator?
So I don't think any day or week is pretty it's the same. We do inpatient care, we do outpatient care. So usually on a typical day, if I'm doing outpatient care, I'm seeing patients either in person, speaking to them over the phone, virtual visits. I'm also running workshops, teaching individuals how to use sensors, insulin pumps and things like that. Beside all that, there's a lot of documentation, a lot of paperwork, a lot of faxing and things like that. There's also a lot of collaborating with the other team members to sort of see, hey, how can we help this person a little bit better? Or this is where I see the challenges. How do we connect them with somebody else? And I think another part of it is also being on top of everything that's happening. When we're at work, we have those 8-9 hours and we're working, but tech is always changing in diabetes. I can't remember in the last 2 years, we've had so many changes to insulin pumps, so many changes to sensors. It's hard to keep on top of everything. So I think another part that you wouldn't see basically sitting in front of us is we're attending workshops, we're reading the articles, we're listening to webinars during our lunch hour, right? So I think it's a combination of all that.
Wow, I didn't take in how multidisciplinary a job can be because you think, oh, okay, well, my healthcare provider is just sitting here. Okay, they're telling me what to do. All right, but there's so much going on behind the scenes, which that's really nice to hear because I feel like I'm never up to date on what tech is coming out. I once got an email about the Libra Mini. I was like, whoa, what's this? And I was like, oh my God, when did this come out? Even when I joined DHF, Rav and one of our other podcast co-hosts, Asta, they had told me about Tandem, which is another type of pump. And I was like, I have never heard of this before in my life, and I felt like so behind. So that is really cool that you get to like attend all the workshops and do all that stuff. That's really cool.
And I think it's really important too, because I know that the people that I'm seeing in my office, they're busy with their lives. They probably have a lot of stuff going on. I do feel it's my responsibility to be as close to up to date that I can be, because then who are they coming to get this information? They're coming to me. And to be honest, there's a lot of people living with type 1 diabetes that I've seen that didn't even know sensors were a thing. So I think it's important for us to be on top of that and to take that time out. And the onus is on us in some way to be up to date, because you don't know whose life you're going to change. With that, just one piece of information could change somebody's life. So I think that's important.
Okay, that is really nice to hear. That makes me feel much more like, okay, I'm going into the appointment and they know what they're talking about. Okay, so now the next kind of like section we want to talk about in this podcast is like the thought process behind your care, kind of like the insider scoop. So like, okay, during like a typical 20-minute visit, patients often share things like their CGM data, their pump settings, so things like the basal, bolus rates. What are some things that you're like quietly considering as you look at that information? Like things that we as patients may not realize because like the info you're using is like you're making these changes to like how much insulin we're getting. So like I feel like that's a really scary change to make. Like how do you manage all that? What do you think about?
I don't focus a lot on the numbers. Um, when you come into my office, I'm looking at how you're talking to me, your body language. I'm looking at a lot more. I mean, numbers are important. I don't want to dismiss that. I need to look at, I'm looking at, yes, your numbers, if you want to talk about that, but then I'm thinking about, okay, how are you affording your stuff? Do you have a support system? Especially if it's your first visit with me, I sometimes find people interact with healthcare providers based on how they were previously treated. So I have to remember not to take that personally because maybe you've had a bad experience and maybe you're going to be catty with me, and that's okay. That's perfectly fine because maybe that experience was bad, right? So I'm paying attention to, yes, what you're sharing, but also what you're not sharing. And then I guess we just take it from there. I'm also reflecting on myself. I've learned this from my kids. Did I word that in a supportive way? Was my tone okay? Maybe I meant to say something, appropriate and that needed to be said, but maybe it came across as nagging. So I always have to be in check with that as well. So I think, yeah, I'm looking at your numbers, but I'm not looking at your numbers at the same time.
That's really affirming to hear because sometimes, like, people have always told me, like, always keep that in the back of your mind that never, like, assume someone's attitude or what they're saying to you is a reflection of what they mean. Like, it could always be a bunch of things, but, like, there have been times with healthcare providers where they have said something, like, a little scary to me. I'm like, oh my gosh. But, like, to hear that you're also constantly, like, reflecting, that makes me feel a bit better because you're right. Sometimes someone will say something and that's not what they actually meant to come across as. So that is nice to hear. Um, in terms of like making decisions about our numbers, do you ever feel like nervous where like if you ever do have to change like basal settings or like change like carb ratios, like does that ever feel like a scary thing to do? Like if you do ever make those changes?
Not really, I'll be honest, because I'm not making the decision by myself. I'll always ask the person. And usually the way my approach is, I'll say, do you want to look at the data or is it overwhelming? Do you want me to make the decision or do you want to make the decision together? Because from years of experience, some people don't like looking at reports and they're like, you just do it. And then some people wish someone had asked them and actually shared that with them to help them understand. So I like to do it together because I want you to know why I made the decision that I did. So if, let's say, we were going to change your carb ratio from 10 to 8, I'll just say, hey, imagine you ate this breakfast and with this number, would you feel comfortable taking that? Because remember, I'm not the one living with it. I don't know how your body responds, right? Some people go for a 30-minute walk and nothing happens to their sugar, and someone just like gets up and their sugars drop. So I don't feel afraid. I'm pretty comfortable doing that as long as I'm having that dialogue with my patient. So I think safety is my priority, highs, lows, yes. That I do, I'll say this is what I think and this is why I think it is. Sometimes you have to be firm, but other than that, it's a dialogue. It's not me. So I feel pretty comfortable.
You're right.
Yeah.
That's a good thing to remember. Sometimes, like in an appointment, it can feel like, okay, this basal rate, let's change it to this, let's change it to that. But you're right. With the dialogue, it makes it feel much more contextualized. So that is something that is appreciated as a patient when you do that. You kind of talked about this already, but like kind of like the things you do that go unnoticed, like you attend workshops, seminars. Can you think of like other examples of like things maybe even in the clinic that you might be doing like while you're with a patient that you're considering and like maybe things that you do that will go unnoticed from our end?
We generally really care about our patients. I know the team members that I work with, we really do. Like to give you an example, you probably know that Dexcom was recently approved for OHIP Plus. And we had a bunch of patients, especially I can remember one for sure, where the only thing holding her back from going on the pump was literally funds. And then being on that sensor really. And when that came out, I remember my colleague and we're like looking at each other and she's like, are you thinking who I'm thinking of? I was like, yeah. And we're like, we can't wait to see her back. So a lot of the things like that probably get unnoticed, and then when we do make suggestions to patients, maybe at their next appointment, we probably discussed it with our team to say, hey, how can I help this person? And I think the other part that doesn't get noticed is a lot of the times it's the mental burden that we carry as healthcare providers. And I think in general, depending on your personality, we feel like we have to fix it all. And if things don't go the way that we think should have gone, and I think we do carry that and say, why didn't it? What did I do wrong? What could have I done better? And I think sometimes patients, I'm not saying that they should take that burden on, but I think sometimes they don't know that we also are human, and we do carry that with us as well.
Okay, wow. I love that.
And one thing that I has kind of already been touched on is kind of meeting patients where they're at. And I think sometimes as a patient, we should meet like our clinicians where they're at in terms of gauging whether or not you want to look at reports or how, like if you need kind of more of that direction. I think it's important to kind of have those check-ins with like patients and your healthcare provider. So I'm glad that you talked about that. And now when it comes to the relationship side of care, so like between yourself and your patients, do you ever wish patients were more open about certain parts of their diabetes? So like maybe information you think would be helpful in terms of providing them care within like their like respective upbringing or like socioeconomic status or anything like that.
So I really hope that my patients feel comfortable telling me things the way they are, not just saying yes to me because I've suggested something. And I think sometimes that does happen. They look at you as an expert, right? So it's like you say something, they don't want to question you. And depending on which background you're from, sometimes we're considered like God. I've heard that in South Asians. And I tell them, it's not like that. Please don't feel like that. Tell me what's on your mind. So I do want them to tell me not just about their numbers, but to tell me if some things aren't going well. So if I'm telling someone, hey, you need to take insulin, it's important that you take insulin 3 times a day, and that's not realistically going to happen, tell me that. Say, hey, Rachna, that's not going to happen. I'm going through this, this, and this. Realistically, I can only take it twice a day. That's it. You're honest with me. I understand where you're coming from. Maybe then I'm not going to push that for a little bit. And maybe I need to look at why it's not happening. So what's that barrier that's preventing you? So I really wish it was a two-way conversation, not a one-way of me saying this is what we need to do. And I want to know what's happening in your life, the goods, the bads, the struggles, what you did really well. And it doesn't have to be diabetes related. I want to know you as a person so I can help you in your path.
That like advocacy part that even we as the patient should have is something like something that I don't think I used to do when I was younger, especially like when my mom and dad were around. I was like, oh, well, I don't want to tell them what's going on in my life. But like finally being in adult care, I feel like that's one of like the positive aspects that you can like now you're there by yourself and now you can like if you really wanted to tell your provider everything that they need to know, which is nice that you welcome that so openly because I feel like that makes a big difference. And it kind of like leads me into my next question. I think one of like the biggest misconceptions of T1D is like there's kind of like a joke around T1D and it's like how if we're about to die because of a low blood sugar, we drink a juice box, which makes T1D sound like such a unserious chronic disease. And I feel like not that that is the whole thing that gives T1D the misconception, but I feel like a lot of times, especially in my experience, some of my healthcare providers have unintentionally, I'm sure, misinterpreted or underestimated what people with T1D go through on a day-to-day day. So kind of like that example you were giving, where like sometimes a healthcare provider will tell me to do something, but it's like on paper, yeah, that's like a perfect solution. But it's like alongside my regular life, I'm taking on the role of my pancreas. Like this is a 24/7 job. So like, for example, carb counting is really hard. Or maybe like a piece of advice they'll give me, I'm like, I don't know how I'm going to fit that into that day. Have you ever like recognized this among the healthcare system where like advice is given in a very black and white, like, oh, just do this? Like, how do you suggest we would like move forward from this and like actually advising our patient or advising patients more like holistically?
I think the biggest thing is I can't speak for all healthcare providers, obviously, but I always feel like whatever worked 10 years ago isn't necessarily going to work now, right? When I grew up, my parents told me something and I did it. My kids do not do what I tell them. There's always that aspect of why, mommy? Like, why don't we do this? I question my parents, right, as I get older, and they're like, well, we never questioned ours. Why are you questioning me? I told you, and that's the way it is. And I think that also plays a role, depending on which educator you're seeing. Remember, they also, just as you have an experience coming from, a different way, they are also coming with their own baggage and their own lived experiences. But I think unless we don't tell them and say, look, you're telling me to do this, but it's not realistic for me. And also, I think healthcare providers also need to be aware that this is not easy. Like if we find without living with diabetes, life is tough. Imagine putting another job on top of that, where you're always thinking, is my sugar going to drop? Is it going to go high? Did I pack my backup supplies? Anything. Like I've had lows where I've forgotten to write a test. I had no idea where I was. I don't live with diabetes, but I've gone through that and I've been scared a lot of the time. So I think that fear is also in there. Like, let's take an example of someone whose A1C might be like 10 or 11, right? Someone might say they're incompetent. Oh, they don't listen. But how do you know that person's having that 9 or 10? Because they're afraid of lows. And they'll do anything to keep those lows away. So I think there's more to the picture. And I think people sometimes group type 1 and type 2 together. People will give advice. Well, why don't you just eat that? Why don't you just exercise? It doesn't work that way, right? I think that part's also there. And I think, again, it's a two-way thing. We have to talk about our feelings. We have to tell. If someone doesn't make you feel right, you have to tell them, say, look, I know you mean well, but this isn't going to well for me. I'm going through X, Y, and Z. This is not going to happen. Because sometimes we see so many patients, I'll be honest, like back to back to back, we forget that there's another person in front of us. It happens to me. Like, seen so many people and there's the next person, I'm already drained. And I need someone to check me back in and say, look, I'm here. And I'm being bluntly honest. That has happened to me, and it does happen from time to time. But I have to remember this is a new individual, new experience. I got to start, from scratch. I don't know if that answers your question.
Yeah, you gotta like clean the slate when you're like fully like,
That's
okay,
right. Yeah.
blank head now, new person here, gotta completely change my whole routine.
Yeah, and you can't judge anybody, right? That's at the end of the day, that's where the misconceptions come in. A lot of times people assume that just because you've been living with diabetes for like 8 years, 10 years, that you know it all. I've done that. I'll ask someone, hey, do you have a ketone meter? And they're like, what's that? Because I made that assumption that, hey, they've had diabetes for so long, they should know,
Yeah.
right? Maybe they learned about it when they were just diagnosed, and now they're like a young adult and no one's talked about it after that. So I think we need to check in with ourselves a little bit more too, not just the patients. Yeah.
I really like how you gave that example about like your low and like how lows are something that can happen to people who don't have type 2 and type 1. 'Cause like I feel like I said, like the juice box example, like people think a low is just like, oh, low sugar, but it's like really scary. Like I know like how someone experiences a low is like very different depending on like what you've been through or like what kind of lows you've had before. But like they can range from like, oh, you're fine, you're chilling on the sofa to like you actually don't know what's going on, you're like confused, you're like about to pass out. So like thank you for sharing that because yeah, lows can sometimes be perceived as like not a big deal, but they are like so scary. Um, Kind of like on the topic like you had mentioned that like sometimes we misinterpret or like give advice based on like kind of like a mesh of like type 1 being close to type 2 even though they are like drastically different. Like in relation to like the healthcare system, um from your perspective, how well is like type 1 diabetes actually recognized in the healthcare system? Like Rav and I, we were talking to an ED nurse on one of our podcasts a while back, and like she was kind of also sharing some experiences that like a lot of nurses don't even know what type 1 diabetes is. And like we were wondering like what your like opinion or like perspective is on this topic.
Well, I think in general, I can talk about when I used to work on the unit. There's not a lot of education. Well, we get education when we're in nursing school, right? But when you're practicing, um, depending on what unit you're practicing on and what you're doing, just because even the ED doctors, right? They know by book, textbook, what type 1 diabetes is, right? But what someone goes through, I'm not sure if all the healthcare providers have a good grasp of that. So I think they do get bucketed in the same way, like feeling exhausted, overwhelmed, all that stuff that comes with type 1. I don't think that portion gets acknowledged enough. Maybe the biology, yes, people know this is type 1, this is type 2, but that extra, and especially in people that are diagnosed with type 1 diabetes later, as older adults, definitely there's a lot of, not enough information out there. They might still think that they're, type 2. So I think that's the biggest thing, the mental burden or the distress of it all. Yeah.
For sure. And my anniversary is in November, so it'll be 28 years since I've had type 1. And I've seen a big change kind of just in terms of diabetes management for myself as someone living with it, but even in the broader context of the healthcare system. I remember reading my childhood records and it was just like, yeah, give Rob Jolt like a unit here and a unit there. So it was, whereas now it's a little bit more structured, there's a little bit more rhyme and reason. So as a healthcare professional, what changes do you wish the healthcare system would or should make to better support both patients and providers in the respective T1D care?
I think the biggest thing is like more education and more training. I think that's really, really important. Even as like a healthcare provider working in diabetes, there's not a lot of funding to support our continuing education. And I'm always advocating for that. I'm like, we're diabetes educators. Like the word educators in there. Don't you think we should get the training that we need or the support that we need to support our patients? So I think that's the biggest thing. It's just, it needs to start from there too. And then also training for other healthcare providers, maybe in urgent care, ERs, things like that. Even on the units, just to give them a general idea, is still better than nothing. I think that's really, really important. Funding is a big barrier in diabetes care. It's shorter appointments, more patients, and we don't have enough time, not enough staff as well, because then there's no funding to hire more staff. That's the second one. The third one would be to have everything under one roof. I, as a person, wouldn't like it if I had to go get my eyes checked somewhere else, my feet checked somewhere else, my diabetes educator somewhere else, my endocrinologist. Wouldn't it be nice to have everything under one roof? I could just know that's my one stop kind of thing. That would be very, very helpful. Like even, someone that maybe specializes in exercise. We don't have many educators that know how to support our patients when it comes to exercise. One, possibly because some of us are not, physically active ourselves. That could be one thing, because how do you relate if you're not coming across those barriers? And because exercise is so personal. Especially elite athletes, that would be really nice to have someone that specializes in that. So those patients have that support that they need, like a social worker, right? Psychologist. I think that whole thing I wish we had all that. That would be perfect in a perfect world.
You saying having everyone in the same room, that is just like a dream come true. Like when I go to
Yeah.
my endo, she's like, have you met with this person? Have you met with that person? I was like, okay, gotta meet with the eye doctor, gotta meet with the foot doctor. You know what? I don't even
Yeah.
think I've been to a foot doctor.
Yeah.
Still on my to-do list. But yeah, having everyone with there, I can imagine that would make our care so much more seamless because then it's like, oh, you want to start training for a marathon. Okay, now your endo's like, okay, that means we should change this basal rate to this, and we should include that. And then your foot doctor's like, okay, if you're going to be running, then you should be worried about this. So I feel like that would be, in a perfect world, that's how
But
it would.
just to communicate, it's seamless, right? I'm not sending or trying to figure out where to send this fax or what to do. Everyone's there. I can go to the next door and I can knock on their door and say, hey, you know what? Um, I'm thinking this. Do you have a minute? Could you come in for a second and just check and chat? That would be wonderful.
That would be really cool. One day, maybe. Okay, so now as we begin to wrap up, um, as our guest, we wanted to ask you what's one takeaway you have being a healthcare professional for T1Ds? So this could be like an insight about healthcare providers' perspective, maybe a tip about advocacy, or even like an encouraging quote. What's one last thing you want to leave with our listeners?
I don't have a quote. I can just say that you know your body best. Please speak up. Please tell us. Don't be afraid. We're not going to bite. We're human at the end of the day. Our job is to give you the education because I think that is important. But our job is also to listen to you. And when you leave our clinic, we're not the ones that are living with type 1. It's you. So whether it's a life lesson related to diabetes, whether it's something that maybe it's a pieces of wisdom or something that you can take once you leave our office and apply it to your life and make your life a little bit easier during those tough times, that's what's important to us. I don't care if your A1C is 5. I don't care if your A1C is 6 or 10. I want to know that, hey, when I was down, when I wasn't doing really well, what did I do to get up again? Or how did I retrain my brain to get out of that? I think that's a win for me. And I hope that's a win for people that are listening.
Thank you so much, Rachna. One, for all that you do kind of within the space of diabetes, and for taking the time to join us today. Your insights as a diabetes educator really highlight the compassion and the complexity behind diabetes care and remind us that there's so much more happening in the background of every appointment.
Yeah, you really like are an ally to the T1D community because like a lot of times we feel like people don't understand what we're going through. So like hearing you talk about like what you're doing in your community and hopefully people are like learning from you as well. I really hope that is really like a nice feeling to have as a T1D. So thank you for kind of like bridging that gap between providers and patients, and we are so grateful you shared it with us.
Thank you for allowing me to come on your podcast.
Of course. And that's a wrap for today's episode. We'll catch you the next time on the Diabuddy Dialogue.
Whoever you are, wherever you're tuning in from, you've got a Diabuddy here.
Beautiful.